All right, so let us start with the first thing. And this is how we're going to do it. We are going to talk about it in sessions like when we pick a part of it, like areas, specific areas in the management. When you meet a special case, how you should go about it, how you should do your things as a nurse. Okay, so that's how we're going to walk through the critical care concepts. So it's not going to be like a form of notes or something, but we're just going to hit on the most important aspects, okay, in terms of the management and the rest. So let's talk about the first thing here. You are a critical care nurse or a nurse working in the ICU. You have a patient who is receiving TPN, total parenteral nutrition, via subclavian venous catheter, of course, central line in this case. Okay. How do you manage such cases? So that is what we'll talk about here. Now, what we have here, we are saying the priority action after placing a subclavian central venous catheter is to check results of chest X-ray to ensure catheter tip is placed in the superior vena cava. What this point is trying to say is that upon the placement of any central line, whether subclavian, internal jugular, we have the peripherally inserted catheters. I think some places we call them PIC lines. Okay, that PICC. Okay, peripherally inserted central catheters. Then we have the femoral one too. So we have different forms of central lines. Any form of central line at all, any form of central line, you are supposed to, after it is being passed, you are supposed to check for catheter placement. Okay, you are supposed to check for catheter placement before you can, or let's say ethically, you are allowed to use. Otherwise, just imagine a catheter tip, not within the vein, but elsewhere. You can just imagine what will happen. All right, so you always make sure that before you use a central line, especially any newly passed central line, you confirm with what? A chest X-ray. Please, not only subclavian or internal jugular, even with peripherally inserted central catheters. Femoral one too, it is ideal for you to check placement using X-ray. That's what the first point is trying to say. Before I even come to the next point, we have lots of indications why someone will need a TPN. TPN is a higher concentrated, should I say, fluid. Its concentration is very high. Okay, in terms of the percentage. Think about dextrose 10%, dextrose 50%. You see how viscous those liquids are, those crystalloids. So in this case, because of the nature of the TPN, we always prefer to give it via central line, but not peripherally inserted line. If you have any question, you can raise up your hand and you can show your hand here and let me know. I'm saying this for the last time. I think it is twice that I've put you on hold. 33983. If you don't change your real name or we don't know you, I'm going to remove you and you can't join again. Please, can you hear me? You can check your name to confirm. All right. And please, when you join, make sure you mute up. Okay. All right. I think we can continue. So we have a lot of indications for TPN. Over here, we're not talking about TPN proper, but we have lots of indications for TPN. Think of any condition and that contraindicates one to eat via oral, okay, or you're taking food via, should I say, via the alimentary canal. So think about perforation. When you have intestinal perforations, you have issues with your guts. I mean, we have a lot of conditions that can affect the gut, okay? Severe diarrhea and the rest, okay, like inflammatory bowel disease and the rest.
Hello, Mama.
When
Okay.
Okay, so I think it's time for me to remove this person. Okay. All right, so we can continue. So we have a lot of indications for TPN, like I was saying. We have inflammatory bowel disease, and like I was saying, the conditions or all conditions that contraindicate us to put food via the gut. Okay. So think about intestinal obstructions and the rest. And these people, we have to feed them. So ask yourself, how should they get their food or their nutrients? So that is where this TPN comes in. Okay. And we have some other conditions or indications why someone will need a TPN. And like I said, and I'm saying again, that it's ideal to use a central line. The second point here, we are saying obtain verification before using this catheter. Okay, as perforation of visceral pleural can occur during insertion and lead to an iatrogenic pneumothorax, especially the subclavian one and sometimes even the internal jugular one. It can cause issues. Iatrogenic pneumothorax or hemothorax due to use of ultrasound guide insertion. Okay. So if, let's say, the catheter tip happens to enter into such spaces, it means whatever thing, if you don't confirm with an X-ray, it means whatever thing that you are giving will end up in this space that the tip of the catheter finds itself. And you're going to cause lots of issues, more than helping the patient. For some of us who haven't seen what a typical central line looks like, this is just a quick one, okay? Let me make it bigger so that we can see it well. So you see how it is.
Oh, what about me?
Kindly mute up for us, please. So you see how it is. This is the, let me see one that has almost all. Okay, so let us use this one and see. So let's use this one. Okay, the one that I have the Keza on. When you have it beside the neck, okay, we have your jugular vein there, so internal jugular over here. When it is done on this vein, then it is internal jugular central venous catheter. If it's subclavian, your clavicle, your collarbone, this major vein lies just beneath your clavicle. Okay. So that is why it is called subclavian central venous catheter. Then this PICC, some people call it PIC line or peripherally. The full meaning is peripherally inserted central catheter. That's the full meaning. So that one too is tapped here, the inner arm just above your antecubital area. Okay. So that one too is there. So this one looks like a PIC line, like peripherally inserted catheter. Okay, so that's how it is. And they are called central lines because we have the femoral one too. The femoral one is picked around your groin. Okay. In the inner thigh over there, your femoral vein. That is where it is being picked. It is called central line because it has a direct connection with your major vein that connects to your heart. So you can see the connections. They have a direct link with the heart. Unlike peripheral lines that will have to go through some branches and the rest. This one has a direct, so it's like you see the catheter, when you insert it, the tip will come as far as this to sit inside the superior, especially with the upper ones. They will come into the superior vena cava. Yeah, the superior vena cava. Okay, that is where they will enter. So they have a direct connection with the heart. That's why they are called central lines. So we can appreciate that. So you can imagine after doing this kind of life, you don't take a chest X-ray to confirm placement. You can imagine what that will bring about. If you have any question on this one, you can let us know before we move on. Okay. If no question, it continues to say that filters are used during TPN infusion to remove particulate matter, precipitates, or microorganisms. Okay, so we should use a special giving set that has a filter. An example, you can imagine similar ones that are used during blood transfusion. It's because of this same reason. You don't want to push into the patient's vein things that are in the form of precipitate or something. Okay. So that is why it's very important for you to use a special giving set that has these filters in them, so that if there are anything that shouldn't enter, these filters can trap them. All right. Then I say TPN uses a hypertonic solution. So example, dextrose concentration of 10%, or we have some which are 10%, some are 50, 15 or 20 or so. So TPNs, they also come in concentrations. Then because of the concentration, it's or let's say the tendency for infection to develop is very, very, very high, especially around those central line sites and the rest. Okay. And if care is not taken, depending on the nature of infection, you can even have a systemic one, or it can develop into a systemic infection. So, microorganisms normally grow well in places where you have sugar, okay, or sugary places. It is very easy for microorganisms to colonize around such areas. So you have to be careful and take your infection prevention precautions very well. You have to monitor baseline blood glucose level and finger stick blood glucose every 6 hours while patient is receiving TPN. Okay, you have to monitor blood glucose every 6 hours while patient is on TPN. And we are saying it should be maintained in a range of 140 to 180 milligrams per deciliter. I think this unit on the NCLEX, you'll be giving both. Okay. I think the milligram per deciliter is widely used in most European countries and the UK. Then other places too, like here in Africa, most places use the millimole per liter. So whichever. Okay, but on the NCLEX, you'll be giving both. You'll not be giving one. So you'll be comfortable. Okay. All right. So TPN, I want us to take an advantage to look more into TPN before we look at some few questions I want to ask you before we move on to the next thing. What else can you say about TPN when you are giving TPN? What else can you say about it? Okay, let me start with this one. You see, whenever, because of the high concentrations of TPN, whenever you start it, you you allow for this thing to happen. Your pancreas produces enough insulin to meet up the glucose needs around that time. Okay, whenever you start any TPN. So at a point in time when your TPN gets finished, or you are making an arrangement for another one to continue and it is not ready, you still have to keep your glucose level around the same level in order to prevent hypoglycemia. Okay, and it will be a very sudden one. So this is what happens. Let's say you are giving 10% TPN, so your insulin level has risen. Up to that point, your pancreas has secreted enough insulin to meet up the glucose needs over there. And at a point in time, your TPN finishes. What are you supposed to do? It is better to give a concentrated crystalloid like 10% dextrose, okay? So that because the concentration is almost the same as the TPN, you can help maintain your glucose level until the next bag is obtained for you to continue. All right, that is one thing to say. Then TPN should not go for more than 24 hours. After 24 hours, when you are changing everything, you change the given set, so you change everything. Okay. What else can we say about TPNs? Do we have to give it by gravity? Are we here? Do you have to give it by gravity?
Yes, it's supposed to be by gravity.
So the use of infusion pumps, I mean, it's more ideal. It's more ideal to use infusion pumps than to give it via gravity. Okay.
Hey, when you said gravity, I was confused. Did you mean because even if it's a infusion pump, you still have to hang it up high. So is that what you mean? Because I know it's true infusion pump, but it still has to be up, not lying flat. So it's still
Okay.
gravity, isn't it?
Okay, so when the use of the normal giving set is more of gravity. That one, when it lies at the same level of the patient, it will not flow, right? But when you're using infusion pumps, though it is, I mean, the standard practice is for it to hang. But even if it's on the patient, it can flow exactly as you've set it per the rate. Okay, so it's like infusion pumps deliver exact volume that you've set, whether it's hanging or it's somewhere. Okay, so what I meant by the gravity was like, I mean, without an infusion pump and you are just regulating the fluid. Okay.
Okay, I
Mhm.
understand. But the reason why I was saying that is even like I work in like a gastro ward and we give TPN a lot most of the time.
Okay.
However, it's still being hanged up high there. We never put if you put it down, it will not flow. Even
Yeah, I'm not
if
saying we should put it down.
because I thought
I'm
you
just
said
giving an example.
if
No,
if,
no,
if you
no.
put it down, it will flow, even with the pump. Even if you put the pump, you still have to hang it. If you put it down with the pump, it will never flow. You have to hang it up and then put the pump through. Thank
It's
you.
exactly as you said, yeah. But I was just citing an example. Okay. No one gives infusion or any fluid by putting it on a patient's bed. You know that is not a standard practice. But I'm just giving an instance. Okay. Uh-huh. So it's like when you set um a certain volume per, or let's say a rate, okay, a certain volume rate per hour. You know, the infusion pumps use the hour one, okay. Uh-huh. So when you set it, it delivers exactly as you set it. And it's the machine, it is the machine which is pulling it. Okay, you don't depend on gravity. So that is what I am trying to say. Any other question or addition? If you want to add up something to TPN administration. So never give TPN just by gravity without infusion pump. That is why ideally most of these things are done in the ICs, or let's say acute care areas. Yeah, let's say acute care areas. Let me use that word. If you have any question at this point, you can bring it out. If no question, then I have a couple of questions to ask you. My first one, a patient is being weaned from TPN and is expected to begin taking solid food today. The ongoing solution, mm, the ongoing solution rate has been 100 mils per hour. The nurse anticipates that which prescription regarding the TPN solution will accompany the diet prescription. Who can help with that? If you want to answer, you can raise up your hand.
Irene,
Okay, it's
I'll take
Irene.
B. Yeah, I'll take B, decrease TPN rate to 50 mil per hour.
Okay, Sister Gloria, thank you. Sister Gloria.
So I'll also go for B. Decrease the TPN rate to 50 mils per hour.
I think this one is quite easier. So I want to use this time to call more. But if you don't understand why the answer is B, you can let us know so that we help you. You know, it's
Please,
like
I
when
don't
you are winning
understand.
off. Okay, it's like when you are winning off certain drugs. You don't have to. Let me give you an example. Let's say which drugs shouldn't even be stopped abruptly. Like this midazolam and the rest. How do we call them? Is it anxiolytics, right? Whenever you are stopping anxiolytics or even inotropes and like no epinephrine, it's the same as no adrenaline anyway, and the rest, you don't have to stop them abruptly. Okay. You know, these inotropes, for instance, they are used to correct hypotension. So when you stop them abruptly, maybe you think you've achieved your targeted mean arterial pressure and blood pressures. So you want to stop it. If you don't taper it down until you stop it gradually, let's say, what I mean by taper it down is, let's say you started at 5 or 10 mils per hour, depending on the preparation. You know, when you are stepping or you want to withdraw the drug, you have to step it down, okay, from, if it's 5, maybe you can have to come to maybe 4.5 before 4, sometimes 1, depending on, what the figures you are getting. You are titrating according to BPs, but when you are stopping, you should step it down gradually before finally you stop it. You don't stop it abruptly. So like this same TPN, the sugar, the main reason is what I explained earlier. You've been given, look at what the question said. The person has been taking 100 mils per hour and you want to stop it. The pancreas has already produced enough insulin to meet up these glucose needs, which are in the which is in the patient's system, okay? Something like that. So when you stop it abruptly, you have, at that point in time, you have the same amount of insulin there, but you will not get this glucose there for the insulin to act on it, to push it into cells. So you are going to have hypoglycemia, severe one and a sharp one. So you taper it down from 100 to 50. Then from there, you can maybe go a bit down, maybe further before you stop it. Please, do you understand it? Or you need more explanation? The person who asked the question, I hear. Okay, let's pick the next question. A nurse is preparing to change the TPN solution bag and tubing. The patient's central line is located in the right subclavian vein. The nurse asks the patient to take which essential action during the tubing change? Who can help with that? Then you add rationale, okay?
So you notice when you take a deep breath, hold it down and bear down, it will prevent air from going into the it will prevent
Yes, that's the answer.
pneumothorax.
So you are taking D.
Yes.
Okay. Any other person? Okay. Hey, no one will want to answer. Okay, let's carry on. So, yes, the answer is D.
Hello, sir.
Yeah.
Can I try and then make some info? Okay. So the answer is D because when you are taking the subclavian tube from the patient, you ask the patient to actually take in a deep breath and hold because you don't want to cause air embolism. So that's why we do that. Yes.
Okay.
Thank you.
Okay, thank you very much. I think we all know this, right? If you are here and think you've done critical care concepts, I think you should meet this one when you were going through your notes. And it is the same for central line removal. Okay. When you are removing central line, especially subclavian internal jugular PICCs, okay, it is important for you to take this step, to take a deep breath and hold it, okay, and bear down, something like that. It helps to increase pressures within your veins. When pressures within your chest rise, you are going to have pressures within the vein also rising. Then what will happen is that you can't have any external air getting into your veins to cause air embolism. So that kind of vagal stimulation, okay, which increases pressure within your chest area and prevents air embolism. So it's the same as removing central lines, okay. All right, and it's the same thing too you do when you are removing a chest tube, Okay. Though we nurses don't remove chest tube. It's the
Recording in progress.
You know that whenever a chest tube is being removed, you, the nurse, you have to educate your patients to do that, okay? So that it will help create a pressure within your chest to prevent air from the outside environment from entering into your chest. All right. So answer is D, you are correct. We have a next question here. A patient with TPN infusing has disconnected the tubing from the central line catheter. The nurse assesses the patient and suspects an air embolism. The nurse should immediately place the client in which position? Who wants to try that for us? Kindly raise your hand. I want the hand raised. Who wants to try? Laku, let's go.
Okay, so with this situation, I'm going for A. So the person will lie on the left side, and then the head of the bed will be lowered. He's lying on the left side, so enable the air to be trapped in the right atrium to prevent it traveling to the other parts of the heart. So with this position, it will help save the person more in terms of management than the rest.
Okay, that is very good. Do you have any idea? Like any other idea from anyone? Any other comments? Your explanation is fine. But is the answer correct? On the left side with head lower than the feet. So that is more of Trendelenburg, isn't it? Head lower than the feet. That is Trendelenburg. Then to your left side. So the rationale is what you perfectly added. So you've done well. Okay. Someone wanted to talk. You can talk. Someone wanted to talk. Oh. All right. So that is correct. Okay. That is correct. So whenever you are removing central line, after, we mentioned before that you should hold your breath in that manner before it is being removed. But before that, you have to put the patient on the left side and in treadmill position. So if you are someone who has been used to treadmill, and you don't meet treadmill, and you meet the words like this, okay, over here, with the head lower than the feet, know that is the same position we are talking about. All right. I think maybe my last question on this TPN and central line things. Maybe my last question, or maybe last but one. So a nurse is preparing to hang fat emulsion, that is lipids, and note that fat globules are visible at the top of the solution. The nurse should take which action? Who wants to try? The nurse should take what action? Laku.
Okay. So with this scenario, the nurse should obtain a different bottle of solution, just because this might indicate that the solution is either expired or something happened. it's supposed to dissolve well. The solution is supposed to be a smooth one, because when you give this, it's going to cause a lot of complications, either clots formations and other things. So you go for the changing of the solution to a different one.
Are you sure? Do you think it is necessary?
Yes, it should be.
Mokobi, do you think it's necessary? This time, are you here?
Hi.
Do you think it's
Uh,
necessary?
Well, it's
Mhm.
what emotion we are coming to give. And so that I think can be possible. So I am thinking you roll the bottle of solution gently so the thing can mix. That's what
Can
I'm
mix
thinking.
well. Good,
Yeah.
good, good. I like your explanation too. This time, we have lots of Amma here. So at least one Amma should talk. Mm-hmm. Who wants to try? Hey, today we have more than 80 people in class and most of us don't want to talk. All right. So you obtain a
Hello.
new one. Okay. Yeah.
Um,
Uh-huh.
I would put it in warm water,
Uh-huh.
so that it will dissolve the precipitate on top
Okay.
of anything. Yeah,
So that you can give it
because
smoothly,
because
right?
it's a lipid.
Okay.
Yes, yes,
So you don't want it to go waste, right? Because it is very expensive. Yes, I understand your point.
yes.
Yes, 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 yes. So you obtain a different bottle. Okay, that is the answer.
Okay.
Okay, remember you are dealing with someone's internal system directly. Everything you are giving is going directly into the veins, into the blood. Okay, you don't have to jeopardize, or let's say you don't have to compromise that. And one thing you should also bear in mind is that when you have a TPN, which is very, very correct and right in its preparation and everything, you shouldn't have these emotions and these globals and some visible things like weird things within it. As soon as you find those things within the TPN, kindly return it. Okay, or there might be an issue with it. So take notes. On the NCLEX, don't give it. And even in rare case scenarios, please don't give it. Okay, I think I have another one here. A nurse is preparing to hang the first bag of TPN solution via central line in the patient. The nurse should obtain which most essential piece of equipment before hanging the solution? Most essential piece. So that's the key word here. Mr. Priscilla Mensah.
Hello, sir.
Yes, sister.
Please, I'll take, yes, please, I'll choose the
Hello?
infusion pump, pump. Yes, sir, can you hear me, please?
Yeah, I
Hello,
can hear you
sir.
now. Yeah.
Yes, I'm saying that I would choose C, the electronic
Infusion pump.
infusion pump. That's, yeah, yes.
Your reason?
So that I'll be able to regulate the flow as I should for the patient.
Okay.
Yes, I will choose C.
Okay.
Yes, that's my.
I like your rationale anyway. Let's see. Okay, so Gloria, Esther Gloria, let's go.
Okay, so I would also go for B, the blood
Okay,
glucose meter. Yeah,
okay.
because we said with the TPN, the baseline blood glucose is important to take.
Very, very
So the first
important.
thing I would do is to go for the blood glucose meter to check the blood glucose. Yes.
Okay, okay. Thank you very much. Can we have a last person to also give us
For me,
an
I will
answer?
also go for the glucose, the blood glucose meter.
Esther
Because
Marian.
yes, please. We
Okay,
said that we need to always check the baseline glucose level every 6 hours.
okay. So
Mhm.
I like what you just said.
Cannot, you cannot give this thing without checking the glucose level every six
Good.
hours. If not, the fellow will risk to get high hypoglycemia.
Good. So you remember exactly what we said some few minutes ago. I like that. Okay. So as you just said again, how frequently should we check the glucose? Mr. Mary,
Please, you said
how
it's
frequently should we check? You
four,
just said it.
four,
I want to
6 hours.
every 6 hours, right?
Yes, please. Yes,
So
please.
now look at the question. The nurse is preparing to hang. We are now preparing to hang the first
Mm.
bag of TPN solution via a central line in the patient. Okay, so which one should we obtain before hanging the solution? Before. So
Okay.
between blood glucose and infusion pump, which one will you choose?
Okay, let's take the infusion pump. Infusion pump.
Good. So you see, because of the frequency of 6 hours that you have to check for RBS from time to time, it will not be urgent. Okay. So, without the infusion pump, you can't even start to wait for the next 6 hours for you to even monitor the blood glucose. So this is one tricky way. Most of the times, when you have NCLEX questions before you, sometimes, I mean, about 90%, we have some questions, whatever it is, it's difficult, but about 90% of the times, the clue to the answer, okay, and the clue to the answer lies within the preamble and everything given in the question. So if you're able to pay attention well, you know your content, you look at the questions well, you understand them exactly as it is, like word for word, you are likely to fish out the answer if you know your content. It will never trick you. So this is one instance, okay. I know most people, or let's say there are more people here who chose B2 as the answers. If you know you are one, smile behind your computer or your phone. Aha, so some people are smiling behind their phones and computers. All right, so the answer is infusion pump. Mr. Menas,
Can I ask a question, please?
yes, you can ask.
Okay. I wanted to find out before we give the TPN, do we need to do a baseline check?
Yeah, that's also important.
Okay.
I get your question,
So,
but in prioritization. Oh yeah, like
okay.
prioritization. Okay. Okay, so
Mhm.
so wait. You can even if you want if let's say we want to protest, we still have some ways around. Okay, the first thing is you want to check your glucose meter, sorry, your glucose level, the RBS
Mhm.
level for you to know the baseline. Okay.
Exactly.
And whatever blood glucose level you will get, it has, I mean, nothing to do with how do we call it? It has no direct link. I'll explain. Okay. It has no direct link. Please mute up. It has no direct link with the infusion that you've not even started. It's just a guide for you to know where you are before starting. Okay. What you acquire, I'm not saying it's not important, it's very, very important. And practically, that should be done before. Okay. But without the infusion pump, you can't even start the whole thing. Okay. So, in prioritization between the two, before starting there, please, infusion pump should be prioritized over the glucometer or glucose meter. Okay, so let us understand
Okay.
it that way. Mhm.
All right. Thank you.
All right, you're welcome. So you see, actually, all of these are important. Okay, some people will even do this urine test and the rest. All of these are important, but what will guide your answer is the most essential piece of equipment. Of course, when someone is on TPN, we do all of these things from options A to B. So A to D. We do all of these things, but most
Can I
essential
ask a question?
thing is the C. Yes, brother, you can ask.
Yes. Okay. So if I may ask, TPN, can TPN be hung without infusion pump?
We normally do it, but that is not right.
We normally do it, and that would
On
be
the
a bolus,
NCLEX,
right?
on the NCLEX, it
That would
is
be a
not right.
bolus.
Sorry, let me come in. In
Okay.
this
Would that be a
in
bolus
this
without the
outside
infusion
world,
pump?
Kindly wait.
in
Wait. Let Nanaya land so that
okay.
sister, you can help out. Nanaya, I'll continue.
Yes. If I understand right,
Uh-huh.
without a TPN basically goes with an infusion, right? And then without a pump, then that means it's a bolus. Is that right? I believe that's what the NCLEX speaks about.
Okay. That is what you want to
I stand
ask.
to be corrected though. Yes.
Okay.
Because I understand, I'm just focusing on the answer because the order for a TPN, I believe it goes in relation to an infusion pump.
Mm-hmm.
Without TPN, basically, the basic principle for TPN order goes with an infusion pump. Or that is not so.
Oh yeah, that is true. That is what you are trying to say. But you were
Right.
trying to
Yes. And
say
then that
something.
means, yes. So I'm trying to build something. That means TPN order goes with an infusion pump. That means the question is relating to what should be done first.
Yes.
I
Like
also
think don't set your own question. What equipment should we obtain first, not what should be done first? Are you looking at the question? Hello? Please, the rest of you, can you hear me?
Yes, we can hear you.
Okay, so I think he is off his network. Our sister who wanted to explain things, I wish Niall can hear us.
Yeah, I'm here. So I was just going to say that.
Oh, okay. Okay. Very well.
Very well. So Zara,
all right.
continue.
Thank you.
Canada.
Okay. I was going to say that anytime we come, like when I started working here, I'm in the UK currently. When I started working, anytime they put a prescription, let me take TPN out, IV fluids. So my supervisor who trained me before I started working, she will tell me, anytime you see a prescription, the first thing you have to obtain is your pump. So we have an equipment store that you go to and pick up the equipment. That is if there is none there. So the first thing I have to look for is the pump before I even come and do checks with the patient. So that explains like what the question was asked. So it's always the first thing, because if there is no pump, you can never start any fluids, because it goes with the pump, because you have to regulate it according to how the doctor have said, like 100 ml per hour or whatever. So you can't hang it without the pump. So the first thing you have to do is look for the pump before you come and do the checks and then confirm the prescription. So that was why I was going to say to him that the pump comes first. So even if the infusion comes with like the TPN comes with the pump, it doesn't mean it's automatic. The pump is coming with the no. You have to look for the pump first before you even do anything else. So that's it. In this outside world, whatever they do is like it's different from what we do back home. Like back home you can hang anything up, but they go according to the rules and regulations. So the pump is first before anything else.
Okay, so thank you for the addition. Okay, you've done well. Thank you very much. So you see, actually, medicine is the same everywhere, and that is what should be done. Sometimes availability of equipment is what sometimes makes us, I mean, some of us do what we do elsewhere. Okay, because let's say if you are prescribing fluid, let's say 3 liters to run for 24 hours. In most cases, or let's say in the Western world, they will give you the flow rate. And even if the flow rate has not even been stated, you should be able to know that 3 liters over 24 hours, I think it will go for, it's 125, right? I don't know if my calculation is correct. You should do that calculation, 3,000 divided by 24. Then
Yeah, it's 125.
125, good. Then you should set your, so
Wow.
it's not like, it's not, it is not actually normal or the usual thing. Let me use this sentence. It's not actually the usual thing giving infusions as boluses, or even as boluses, you can use these pumps to give boluses, like by gravity and errors. Sometimes it's availability of equipment, but as long as the eggless is involved, okay, we should always be previewed to the set standard. Okay, to the set standards. We have to abreast ourselves with that, because those are the areas that we're going to operate. Okay. So thank you, Zara, for that addition. Any other question? Hey, okay, I think I have a bonus question here. Someone should just tell us the answer and let's go. It's not difficult because I even mentioned it. You're making initial rounds at the beginning of the shift, and you know that the TPN bag of an assigned patient is empty. Which solution should the nurse hang until another bag of TPN is mixed and delivered to the nursing unit? You know, I said this. So what do you think will be suitable here?
Option B. 10%.
10% dextrose. Good.
10% dextrose.
Good. I hope we all understand. We are all on the same page, right? Okay. So let us look at another thing here. I know those of you who have gone through critical care concepts, most of you met this, but some understood, some didn't understand, right? Mr. Priscilla, you have a question?
Yes, sir. Please, concerning the previous question, is it 10% dextrose because that's the like highest hypertonic solution over there? I just want to be sure. Is that
Yeah,
why we
so
are choosing? Okay, sure.
okay,
All right.
so
Thank you.
you're welcome. You know, I mentioned that I think when you Google, you'll find something like that. We have different concentrations of TPN, but the least you can get, of which I have seen, I don't know whether there are some others which are more lesser, but the least I have seen is 10%. Okay, we have I think 20% or so too.
Okay, thank you.
Okay. So the TPNs are in that concentration. So if you want to change or to switch back and the incoming one is not ready yet, you still have to keep your glucose level around the same point as you were taking the TPN, so that you don't run into severe hypoglycemia in wait for the next one. So that's the reason. Are you okay? Okay. Please, I hope you understand. Phlebostatic
Yes,
axis.
please. Yes, sir.
Okay.
Thank you.
You're welcome. So phlebostatic axis. As nurses, you have to know this axis to help you monitor your CVPs, I mean central venous pressures, and arterial blood pressures and the rest. Okay. So this is just an anatomical position. You have to know this position. All that you have to know as a nurse is just know this position. If you get questions on it, or even in like these things we are going through, they are life, they are life things, and they are very evident around our practice area. Unless maybe your hospital, your current hospital or your ward is not like a best site, like a major one that have those equipment. If you don't have those equipment, then that is fine. But they are real things that, if you are here and you've dealt with it before, you know what I'm talking about. So the NCLEX is also interested in that. Phlebostatic axis is an external anatomical point on the chest at the level of the atria of the heart. So atria of the heart, around your fourth intercostal space, static axis. It's an anatomical point on the chest at the level of the atria. That is the fourth intercostal space at mid-axillary line. I will show you very soon. Or midway point of the anterior posterior diameter of the chest. So let me take you here. My picture is a bit blurred, but I think we can see the human being or the man lying down. You can all see, right? So let me use this as an example. So your intercostal space, if you want to identify the phlebostatic axis, you start counting your intercostal spaces. So you have the first one, second, third, let's say this is the fourth one. It's just a sketch I'm making. Let's say this is the first, second, third, and let's see if your fourth one lies somewhere. Oh, let me do it well. So let's say this is your first one, this is your second, this is your third, and let's see this is your okay, fourth intercostal space. Let's say it falls here. So that is your line mark. And we are saying on this mark, okay, your anterior posterior midline, the middle of it, okay, your anterior posterior midline on the fourth intercostal space. That is where you have your atrial, leveled around that point. So this is your phlebostatic axis. At a point in time, you will not meet anteroposterior midline, okay, but you meet maybe mid-axillary. Okay, I think we wrote it somewhere here. Let me see.
Push it to your end.
Okay, at mid-axillary line. Okay, mid-axillary line. So if you don't meet anteroposterior midpoint, okay, the midpoint, and you meet maybe mid-axillary line on the fourth intercostal space, the same point you are talking about with respect to phlebostatic axis. Okay, so someone will ask, why are we even talking about phlebostatic access at this point? What is it? Why is it necessary? What
You
is
wash
it
it.
doing here?
Wash it and rinse it. That's why I wash this thing. Mine, put oil in it.
So this person will come and ask, what were we talking about? Hey, Sister Esther, please mute up for us, okay? Okay. So, like I told you, the position helps us to monitor accurately CVP, that is central venous pulmonary arterial lines. Okay. So it is a guide, or it guides us where we should keep our transducer, okay, at a certain level, or it tells us at like which level we should keep our transducer. Let me show you something small about this setup. This is a screen or a monitor for invasive monitoring. Okay, it's like a normal cardiac monitor, but you know some of the cardiac monitors can monitor invasive procedures too. Some cannot monitor, but in this case, you have to get one that can be used to monitor invasive procedures. Okay, like what we are talking about. This is just a fluid, normal cell line. Okay, you can see a pump wrapped around it, like an infusion bag pump, because you have to create a pressure here. So it's like you have a given set connected from here to the transducer. This is the transducer. Okay, what you have here is the transducer. So you have this normal cell line connected to this transducer, and we have a connection from the transducer to the screen, and another connection from the transducer to the patient sitting in there. So this one is in the artery. Okay, depending on what you are monitoring. If it's arterial blood pressure you are monitoring, then in the arteries, then you have this fluid also connected with high pressure here. So what the transducer does is to detect the pressure here and convert it to an electrical or let's say electronic display on the screen for you to know what is really happening within the veins or arteries of the patient. So it picks up the pressure in here, okay, then convert it into a display over here. Okay, why we are interested in the position or the level of this transducer is that if you don't keep it at this phlebostatic axis or this line, please, you see, we took the point from here. We measured the fourth intercostal space, mid axillary line or anteroposterior midpoints. It doesn't mean that the transducer should be here by force. No. So this one shows us that, you see, we have an inverted or should I say projected lines throughout the patient. Okay. So we want our transducer to remain around the same level. So the transducer can be here. So this is just a stand, okay, a drip stand. So this can be here or it can be anywhere. But at the end of the day, what we are interested is let your transducer be at the level of the phlebostatic axis. That is the only way you can get accurate results for whatever thing that you are monitoring. That is why it is important for us to know this phlebostatic axis. Are we picking something up? Or it is like a blurred video for us? Okay, if you have any question here, you can ask. I think some of us here have seen the setup before in our hospitals. Some of us, we are yet to see. So this is a phlebostatic axis we're talking about, okay? And what the transducer does. So when you keep the transducer at a higher level or at a lower level, you're going to get false values. So that is it. Now, let's come back to what we have here. So you're saying it is used as a zero reference point for correct placement of the zeroing point of the transducer when measuring continual arterial blood pressure, central venous pressure, using central line, and or pulmonary artery catheters like the Swangans. I don't know if that's the right pronunciation, but some will pronounce it this way, Swangans catheter, okay? So we have something we call zeroing, okay? You have to, this thing, it's more practical, but it is like whenever you set it up, okay, or you take up this patient, you want to begin monitoring, you have to zero this transducer, okay. So we have I don't even know how to make this thing more visible to you. I mean, it's like a settings that you have to, I think, should I say through it up? The transducer, I don't know how to describe the transducer to you, but well, it is not necessary here. What you have to know is that it's relays the pressure coming from the patient
Hello?
to the play, okay? Then zeroing,
Hello?
the whole thing is done on the transducer. Yeah. So if you
Yeah,
want to talk, you
hello.
can put up your hand for us. Yes, Tama.
Yes, please.
Okay.
I want to help a little bit with the transducer.
Okay.
So, like, just relating it to the image you showed us on the screen. It's an arterial line, and then you connect a three-way tap to the arterial line, and then you connect it to your transducer. So when you zero, while you are zeroing, you close to the patient, you zero before you open. Then the pressure, it will pick the pressures within the artery. And the zeroing is like the settings, it's a settings that you have to do on the monitor. So when you zero, it gives you a waveform to indicate that it has picked the signal from the artery. And then you close it, you open to the patient, and then it will be able to check the blood pressures. And most of the times when you do it, it is a continuous monitoring, sort of. But once in a while, when the patient moves or something, it can dislodge, and then you have to go through the process of zeroing again. So
Yes.
that's
Yes.
it.
So thank you very much. I understand what you're saying. I'm just picturing it in people's mind. Is that Priscilla? You also
Yes,
want to add up.
yeah, I just wanted to add up. What
Thank
I
you.
know is
Our
usually
critical
at
care
my
nurses are talking now. All of you should talk.
usually at my facility we usually use it for patients that will be doing long surgeries for like spinal surgeries where you would take long, so then it's an invasive blood pressure monitoring, and it's usually connected with the normal saline. Is usually heparinized. Then you connect it so that in case it helps with the pressure, so that you'll be able to, I mean, with arterial, the arterial pressure is more, I'm just saying like, it helps with arterial pressure, and then usually you connect it to a heparinized saline. That's what I wanted to add. I mean, and it's usually
Okay.
done intra-op during the procedure, yes.
Okay. Okay, thank you. Thank you. Thank you very much for your additions. So our critical care nurses are talking. So mostly in cardio and neuro, for what I've seen, okay, in cardio and neuro
Hello.
patients, that's what I've seen these days. Yeah.
Hello?
It's a Rosemary.
Yeah.
You want to
Yes,
talk?
yes, please. The hyperline saline, not really keeping the pressures per se, but it helps to maintain the patency of the line. So you realize that we only use only I think 0.05 of the heparin to mix with the
Yeah.
saline before we hang it in the pressure bath. So it just keep the patency so that it doesn't cause the lines to become clogged up with any blood and all that. Thank you.
Thank you, our critical care nurses. Thank you. Sister Patience, your hand is up.
I'm not a critical care nurse, so I'm just asking a question.
Oh, okay.
So my question is this: to get the phlebostatic access, all right. So, is it done manually
Oh, everything, I mean, you that
or
look at the kind of English I'm about to speak. I mean, you do it physically. Everything you see here is being set up by the nurse, or I mean, you can actually set up this. I think our critical nurses are trained for that. But you know, in the settings where we want to find ourselves in, nurses can set up these things. If only you work in the ICU or areas where you should use these things, you can set it up. But it depends on the protocol too. I think, you know, there are some things that in the US you'll be allowed to do, but UK nurses are not allowed to do. So it depends, okay. But when you are trained around the area, you can't even, I think in the UK, I don't, someone just said that once ago. I don't know whether it's still true. You can't, please, can you set IV lines? Any UK nurse here, can you set IV lines?
I think they have their own phlebotomist though.
Something like that. There's a time someone was telling me something like that, and well, so this is the NCLEX, okay? Here we are. I mean, we are doing NCLEX. So with this one, you see, this is actually a drip stand that you pick. So you actually fetch this drip stand. This is just a monitor. In most cases, the monitor will already be in position. Okay. So you will set up these things. I think in most settings, they normally even attach this transducer to the drip stand or something like anything, all that you have to. So you see, all that we are studying for the purpose of NCLEX, what you should know is the phlebostatic point. Please, whatever you do, don't forget the point we mentioned, fourth intercostal space, mid axillary line, or midpoint anteroposterior line. That is your level of your transducer. Whatever it is, don't forget that one for your NCLEX. So that is one thing. All that we are saying, we are just trying to help you understand the setup. Okay, but for the purpose of your NCLEX, know that this setup is used in central venous pressure monitoring, arterial blood pressure, invasive one, okay, arterial blood pressure monitoring, and this pulmonary artery wedge pressure monitoring and the rest. So that is why that is where you need these settings. You want to know the actual pressures in these areas. Okay, when you tie a cuff around the patient's upper arm and you are checking the blood pressure, when you check the cardiac monitors, you will see this NIBP, which means non-invasive blood pressure. Okay, but these things this setup, for instance, it's invasive blood pressure monitoring if it's only in the artery. Okay, so that is what we want you to understand. As at what goes into the setup and the rest, maybe we shall get another time and learn, but the NCLEX will not be interested in that. So what the NCLEX will want you to know is what I'm telling you, the position of the phlebostatic axis. And you should also bear in mind that that is the level where your transducer should be. I've told you a bit about what the transducer does. Okay. So I think this alone is even enough for this one with respect to English. Any additions are just for learning purposes for you to know how it's actually done. Please, any question on this one? So thank you all for your contributions. Okay, my critical necessary. Now I know you are here, so let me hear your voices. Okay, don't hide. Don't hide under the shade. Let's look at some questions here. The intensive care unit nurse educator will determine that teaching about arterial pressure monitoring for a new staff nurse has been effective when the nurse does what? We just talked about this one. Everyone here should be able to tell the answer. So please raise up your hand. Don't just unmute. You can show your hand here so that we call you. Okay. Hey, no one wants to talk. Talk to me. Or we should move on. We all understand. We all know the answer. Black hole.
Okay, so I'm going for the option B, positioning the zero reference stopcock line level with the phlebostatic X.
Exactly. I just said this, so we even need not to waste time on this one. So that's the rationale. So we can go through quickly and move on to the next one, if only you don't have any question. But if you have any question, you can ask. The class is for us, so try and understand everything we are doing, okay? It will help you a lot. Okay, so I think that was only one question there. Let's look at ventilators, okay? So ventilator malfunction and what to do. At a point in time, you are caring for a patient who is being intubated on a ventilator, and you notice that there's a ventilator malfunction. What would you do as a nurse? So let us go through what we have here. Then if I have other instances or any other thing to add, I will do that. So a low tidal volume alarm indicates that the volume of air the ventilator is delivering is lower than the set volume. So we have lots of parameters to pick up from the ventilator. Lots of parameters. Okay. Minute volume or minute volume, tidal volume, is it minute ventilation or something? Minute ventilation or minute volume, one of them. We have tidal volume, FiO2, which is fraction of inspired oxygen, PEEP, okay, positive end expiration pressure, and some other things, okay, pressure support and some other things we can pick up from the ventilator. But on the NCLEX, what the NCLEX is normally interested in is the high pressure alarms and low pressure alarms, okay. A low tidal volume alarm is like, take it as low pressure alarm, or let's say yes, low pressure alarm, something like that, because they have they are similar things, okay. The causative things, or the things that can cause these low tidal volume alarms, they are almost the same as the low pressure alarms, okay. So the English is much interested in that, rather the high pressures and the low pressures. I think most of us have already come across that before. Yes, and maybe some few other things, but not into details. Okay. So there is a general rule before I even go through this with you, there's a general rule. Whenever, but it depends on the question. The rules are there if only you understand what you are doing, but questions can be very, very different. So I will always say it depends. But let us look at this situation. Whenever you are caring for a patient on a ventilator, especially intubated patients, you know that the only way the person is breathing is through that tube. The patient is not breathing through the nose, nor the mouth, only through that tube. So you don't jeopardize with the only route or route the patient is breathing through. Whenever anything happens on the ventilator, let's say an alarm, the first thing to do, okay, the first thing to do is to check up on the patient first before you check up on the machine. This is like a general rule. Okay, whenever anything is happening, whether with even infusion, pumps, and the rest, whichever thing that is happening, check on the patient first before you check the machine. Don't go and check machine before you check on the patient. And I think that makes sense. So it depends. If on the question, sorry, within the question, they've given you an idea of enough assessments. Okay, let me try and see whether I can form a question here. You are caring for a patient who is being intubated on a ventilator. Okay. The ventilator starts beeping. Okay. Meanwhile, patient is in no visible distress or something. I mean, the question goes ahead to tell something about the patient. It is trying to tell you that an assessment has been made with the patient. And for that matter, your next line of action should be on whichever thing that is causing that alarm. So you check on the machine. That is a different scenario altogether. But if it's just an open question like you are caring for a patient on the ventilator and the ventilator starts giving you low tidal volumes, what would be your priority action? In a question like this, look for options that assesses or address patient needs first before you go and do your troubleshooting on the machine. So that's the general rule I want us to take note of. Okay. Now let's look at what we have here. A low tidal volume alarm indicates that low volume of air the ventilator is delivering is lower than the set volume. So you've intubated the patient, normally, like right now that I think none of us here is intubated, and I'm sure of that. So as you're breathing right now, there's an amount of, or let's say there's a volume of air you draw into your lungs, okay? But for this intubated patient, we control all of that. So when we intubate patients and we put the patients on the ventilator, we determine the amount of air, or let's say the amount of oxygen that, when I say amount, let me use volume. We determine the volume of air that should go into the lungs by setting it on the ventilator. Okay, there's a calculation for that. It's not necessary here. You will determine that. Okay, so if at a point in time what we've set on the ventilator is delivering something lower than that, then it means you have some of the air leaking through other areas. Then that is where you now come and search for what is really happening. But like I told you, if the patient, let's say at that point in time, patient is in visible distress, you have no time to waste. You have to disconnect the ventilator and bag patient. Okay, you connect your bag valve mask and you bag patient on oxygen. Okay, 15 to, let's say, around 10 to 15 liters, but mostly 15 liters per minute oxygen rate. You bag patients until the issue is being resolved. Okay. So if you have a low volume than what has been set, it means there's an issue. So we are saying this is most often due to a disconnection. So it can be a disconnection, it can be a loose connection, or even a leak in the circuit. When we talk about the circuit, sorry, when we talk about the circuit, is the connection that we've made. For those of us who are not used to these things, let me show you quickly so that we can move on. So you see these pictures. This person has been intubated. This is the endotracheal tube, ET tube. So let's say this is the ventilator. Okay. So this is the circuit you're talking about. Let me pick my pen here. So this is the circuit you're talking about, the circuit. So it can be that there's a leak circuit or a loose connection, or maybe it has even disconnected or something like that. Okay, so when we talk about the circuit, this is the circuit we're talking about, the connections. All right. So the next troubleshoot the most common causes of the alarm. But if the client's condition is deteriorating clinically, okay, example, like patient is having a decreasing oxygen saturation, or a visible respiratory distress, like maybe nasal retractions, intercostal retractions, like nasal flaring rather, nasal flaring, intercostal retractions, chest indrawing, and all of that. Those signs that indicate respiratory distress, then you know that maybe what has been or what is happening might have been happening for some time now. Okay, let us all mute now, please. Unless you have something to say. I hear feedback. All right. So that is it. So when that happens, let's say if patient's condition is deteriorating in the heat of this, what are you supposed to do? You are saying then the nurse should disconnect the ventilator and manually ventilate the client's lungs with a resuscitation bag, okay, at a rate of 10 liters, 10 to 15 liters per minute oxygen until the ventilator alarm state can be resolved. So that is it. And we are saying ventilators may sound an alarm when set parameters are not being met. Yes, so it is like when you have a cardiac monitor, you set alarm limits. So at a point in time when when the monitor, whichever monitor you are using, when it is giving you a value which is not within your set range settings or your set range values, then these alarms will be beeping. Okay, let's say for heart rate, you've set the cutoff point to be 50 and the highest point to be, let's say, 120. So when it goes below 50, it's going to give you an alarm. When it goes beyond 120 to give you an alarm. So this one depends on what you set on the machine. Okay. You are saying these alarms. Is someone talking to us? Okay, these alarms may indicate a client's condition or ventilator malfunction. So if a ventilator alarm cannot be readily resolved, the nurse should manually ventilate the client's lungs with a resuscitation bag device. I think we've also said this one already. If you have any question or any addition, you can add up. So I think we will talk about the pressure alarms very well as we move along. Okay. It's more detailed ahead of us. Any question? Any addition? All right. If not, then we will continue. Let's look at another thing here. Emergent treatment for hypovolemic shock. Emergent treatment for hypovolemic hypovolemic shock. So, we have different types of shock. We not go there, but we have anaphylactic. Which one again? You have lots of shocks. Okay, lots of shocks. But we are looking at emergent treatment for hypovolemic shock. So, when someone is having hypovolemic shock, what should we do? That is what it's trying to tell us. So the first one here, we are saying never place head of bed of patients with hypovolemic shock in high Fowler's. That is 90 degrees position. And the reason is that it causes VP to decrease, especially with hypovolemic shock and inadequate circulatory volume. I think someone has brought this up before. The person saw it in Let's Achieve. Maybe some of you too, you've seen it. Okay. Just in case one day you meet such thing. The reason for this thing you are trying to say is that you see look at the words again. Never place head of bed of patients with hypovolemic shock in high Fowler's. When you have hypovolemic shock, you have decreased cardiac output, like low stroke volume. It means that low cardiac preload. That is what I wanted to say. So it means that whatever amount of blood that is coming to the heart to be pumped is reduced. Okay. So when you raise head end of bed of patients, you are further reducing blood returns. Okay, you are further reducing blood returns to the heart. And in hypovolemic shock, what we want to do is to gather more blood sent to the heart so that the heart can pump to vital organs. And at a point in time, or let's say through all points, okay, in times, you have vital organs being perfused. That's the reason for this. So when you put patients in high Fowler's position, you are further reducing venous returns to the heart. And that further causes a decrease in blood pressure. That is why you see it at places that whenever you have hypovolemic shock or low blood pressure, okay, you have to put patients in the Trendelenburg position. So it's like, you see, at some sources will not also tell you Trendelenburg position. They will be like raise foot end of bed or elevate foot of patient. So it is for this same physiology of returning blood from the lower part of the body to the heart to be pumped into systemic circulation to help temporarily. Okay, it's not a permanent solution to hypovolemic shock, but just to help temporarily with the condition. Okay. So let us stick to this one. Let us stick to this one. Now, ask yourself, is it ideal to give furosemide in hypovolemic shock? What furosemide does is to decrease left ventricular preload, okay, in cardiogenic shock. But in hypovolemic shock, you even need more blood to come to the heart to be pumped. I don't think furosemide is needed. Okay. Norepinephrine, for instance, over here is a vasopressor, and it helps to increase the stroke volume. When you say vasopressor, think of vaso. When you hear of vaso, think of vessels. Then pressor, it presses on the vessels. So norepinephrine and some other, not all inotrope, but okay, let me stick to norepinephrine. So it's presses or constricts blood vessels, okay, especially the arteries, so that you can have your stroke volume increase and cardiac output also increase. You see, when you have a wider lumen, you will need more blood to be able to pump blood through that vessel. But when the vessels becomes constricted enough, it means you need lesser amounts of volume, okay? And that will catch up, or it will meet up with the little that you are left. And that will ensure enough perfusion and give you your desired results. That is why norepinephrine and some of these things, these vasopressors, are used in management of this hypovolemic shock and hypotension and the rest. Okay. So this one continues to say titrating norepinephrine infusion upwards to maintain mean arterial pressure within normal limits. You see, for mean arterial pressures, you should get them above 65. The least cutoff point is 65. Some books will tell you from 70 to 110. Some will tell you from 70 to 100. Some will tell you from 65 to 100. The lowest you can get is 65. No way beyond. And with the highest you can get is 110. No way beyond it, or unless you're above it. Okay. Mostly you see 65 to 100, but some sources will give you up to 110, but you shouldn't cross. And when they want to ask you questions about abnormal mean arterial pressure values, they are not going to stick within this -5 minus like +5 or something. In terms of talking about the 70 to 100 range, okay. So whenever you get mean arterial pressure of, let's say, 60, you know that it is low. Okay, anything below 65 is low. Then, okay, so that's it. Then with the last point here, we are saying with decreased peripheral tissue perfusion, who are receiving vasopressors, pulse oximetry readings are usually more accurate when the sensor is placed on the forehead rather than on the finger. So when you are, so you see, this is another clue. It's very practical. It's very, very practical. When someone is on these inotropic support or vasopressors, and you take pulse, please, let us take this serious. Maybe you can meet it somewhere on the ankles. It will be more ideal to check the patient's oximetry, okay? Pulse oximetry, either on the forehead, at the earlobe, or any other place possible, except the finger, okay? Let me show you something too. Yeah. You see how it looks like? Okay. So some are like this. Some are even attached to the earlobe, like, over here. And so we have different forms of it. So that's what we're talking about. All right. So let's continue. Any question? But are we here? It's like I've been talking for some time. Are we here? Are we all paying attention?
Yeah, we are following you.
We are here,
Okay.
but
Okay. Then let us take this question to freshen up. Okay. What will the nurse identify as symptoms of hypovolemic shock in a patient? Select all that apply. Who wants to try first? Okay, with the select order apply, let us do it together. When someone is having low perfusion to tissues or to vital organs, in fact, that is what is happening in hypovolemic shock. When the shock comes in, it means organs are in danger. You know, we have general hypovolemia, but when the shock comes in, it means some organs are in danger. Okay. So, what signs and symptoms would we see in someone with hypovolemic shock? In the first one part, can we add it?
No.
No,
If no, why?
because the temperature goes down rather
Okay.
extremely
It is not
down.
my
So
handwriting. It is your own handwriting.
Yes,
Restlessness. Will it be
Yes.
there?
yes, yes,
Yes.
Okay.
yes, because there is
Decrease
poor
in blood
perfusion.
pressure. Okay. So
Yes.
this is more like orthostatic hypotension, right?
Yeah.
Okay. So that is there. For capillary fill time greater than 3, will it be there?
Yes,
Yes.
yes.
What's the normal one? What's the normal capillary fill time?
Less than
Less than
less
3
than
seconds.
3 seconds.
Less
Less
than
than 3
3.
seconds.
Good.
Less
Less
than
than
2
3.
seconds. 2 seconds.
So up to 2 seconds, right? Or less than
Oh,
3.
okay.
Same
2
thing.
seconds. It's less than 2 seconds.
Oh, but when you get to it,
It's
it's
up to
okay.
3.
Yes, when you get to it, it's
1
okay.
to 3.
So some do you know that there are some who even consider 3 to but it's like 3 is the marginal. But the ideal one is it should be less than 3. That's the ideal one. Okay. Then the last one, sinus bradycardia of 55 beats per minute. Is it true?
There'll be tacky. There'll be tacky instead.
Okay.
Borderline.
Good. Good. So this is not part, right?
No.
Yes, it's not part.
Okay, so we have 2, 3, 4. 2, 3, 4. So please, I hope we all understand why there will be tachycardia instead of bradycardia. Unless you ask, but if you don't ask, I presume you all understand. Okay, so let us see. So the answer is 2, 3, 4. So we are correct. Your handwriting was correct. Okay.
Yay.
So let us go through the rationales quickly.
Hello.
Yes, sister.
Hello, sir. Please, after this, I have a question to ask.
Please, you can ask.
Okay. Please, thank you for the presentation. Please,
Okay.
I would like you to throw more light on the medication, especially the furosemide.
Okay.
Like when you explain it's a kind of a bit confusing to me when it comes like the patient has lost blood and the blood also deals with water and you are giving the patient lysis or something. Won't it affect?
Yeah.
So I want you to
Yeah.
throw more light.
Okay. So I said, if you remember clearly, or if you heard me clearly, I said furosemide won't be needed. Okay. Because the person is already having hypovolemia. The person has lost blood, or let's say blood volume. When you say blood volume, it makes sense. Whether it's more of the water part. Okay. And you know that furosemide is a loop diuretic, right? So it will help you lose more water, throw more water, and some electrolytes out, especially potassium. Our concentration here is the fluid. So someone in shock, why would you even give furosemide? So it's just over there as a sensation to you that in case you get a question and you have it there, that should be part of the answer. Please do get me.
Yes, please. I'm not clear with it.
Okay.
Thank you.
You're welcome. I think we've gone through this one, so we can move on. We have another one here. The nurse recognizes that which patients will be most likely to develop hypovolemic shock. So among these four, a patient with what? This one, it should come with rationale. Know why you choose your answers right from day one. Okay. Who wants to try?
It's one. Hello, I think it's one.
Okay.
One, because the decreased cardiac output. If the heart is not able to pump enough blood to the extremities, definitely the lower extremities will be the blood volume will be less for the vessels, causing the shock.
Hypovolemic shock. Okay, let me get more views on that. Thank you for your submission. Can I get any other person? Or maybe I should mention names, right? When I mention your name, don't run away. Mr. Benis, let's go. Mr. Benis, what? Okay, any other person can come in.
Hello, sir.
RN Comfort.
Yeah, this is this is comfort. So I am thinking of 4, even though I don't have confidence, but this is my explanation. So the SIADH is if the patient is to have appropriate antidiuretic hormone, it means that the patient will be able to conserve some fluid, okay, from the kidney. But because patient has inappropriate antidiuretic hormone, whatever fluid that is going through the kidney or is in the body is actually being removed without the hormones being sensitive enough to withdraw some. So in such a case, often they have hypovolemia, they are losing a lot of fluid, and then mostly when you see them, you have to give them IV fluids just to sustain them before you can correct the hormonal stuff. So I am thinking that maybe it might be 4. Thank you.
Okay, you're welcome. Okobi, you talk.
Fatima, I want to
Let me ask you. So should you get this question on the NCLEX? Just think about it. This is a typical example, or it can be a typical example of NCLEX question. Will you let this question go for free? Mukubi, come in before Mr. Gloria comes in. Your hand, please.
Okay.
You can raise up your hand.
Sir, hello. Okay, sir.
Yeah, Mukubi, let's go.
I beg to differ with what she said. She's talking about diabetes insipidus with SIADH. They are holding all their fluids, and so such a person cannot go into hypovolemic shock.
I didn't want to say that earlier because I wanted to listen to your views.
Right.
Okay, so let's go.
Yeah, and with the second option, it says severe constipation. However, causing watery diarrhea, I'm kind of confused. And so as much as I don't know, I'll just go with 1.
You go with the first one. Okay, thank you. Hey, some people are throwing away their marks on the NCLEX right now. But don't worry. Whatever thing that you said, it can be correct, but I just want to challenge you and see. Mr. Gloria, let's go before Sarah.
Okay, so I think I'll go for 2.
Okay, so wait. So there's another name for option 2. Who can? There's a nice name for 2. Who can tell us? constipation that make you leak watery stool or diarrhea? Who can tell us? Okay, you carry on after I'll bring that up.
Because I'm thinking with the decreased cardiac output, it's as a result of a cardiogenic shock. That's what I'm thinking. And then with the ascites, I know it is accumulation of fluid in the abdomen. That is not that one. I don't think the client is losing fluid rather. And then with the SIADH, the clients will rather retain fluid, not losing them. That's what I
In this
think.
case, your answer will be
I think I'll go for 2.
okay. Thank you. Sarah, let's go.
Okay, I'll go for 3 because with ascites, the fluid is moving from the blood, like the intracellular to extracellular, into the tissues. And then intravascular. And when this happens, it can also lead to hypovolemia, even though the fluid is not out physically, maybe through vomiting and diarrhea or bleeding. Patients can also be hypovolemic. Thank you.
Okay, so you choose 3.
Yes, please.
3 that someone eliminated first. Okay, thank you very much for your submission. Laku will be the last person to talk. Unless someone wants to also say something, you can raise up your hand.
Okay, so
I see you.
I'm going for the option 1. So when there is a decreased cardiac output, it leads to organs not getting sufficient blood supply to function. And then with the option 2, with severe constipation, I know when people have constipation, after most of the time after the constipation, the next thing that comes about is diarrhea, which is a normal findings in the constipated person. And then with the ascites, I'm not going for that. There's already fluid in the system. And then also with the SIDH too, fluid leaks to the cell. So I'm also not going for that. So I'm going for the option 1.
Hello. Hello.
Hello.
Hello.
Oh, sorry, my network took me off. So what was your last, part, the answer?
Please, is it me?
Yeah, like you were talking, right? My network took me off, sorry.
Okay, so you want the last one with the SIDH or?
Your answer.
So I went for option 1. I said when there is decreased cardiac output, that will lead to insufficient blood supply to vital organs, which can lead to shock.
All right.
With the severe constipation, when there is constipation, most of the time when they are being relieved from the constipation, the next thing that comes is diarrhea, which is an expected findings in constipated people. And then with ascites, there's fluid in the system already. Then with also the SIDH, there's also fluid leaks to the tissues and the cells. So I will go for the option 1.
Okay. Esther Ruth, did you want to say something?
Please, I want to add up to my colleagues who chose the option 1. Hypovolemic shock, there is an indication that the fluid volume of the blood is reduced. And through your presentation, you said we shouldn't raise the bed. We should allow the bed to be down so that the blood flow will go to the vital organs. And so, like, there's deficits in the blood volume. So definitely.
Oh, continue.
I've seen the answer.
Oh, continue. I'm enjoying your explanation. Come on. Oh,
So
okay. So you see, what most people least expected. You see how the English can be tricky. That is where the answer lies. And the explanation is what our sister said. I've forgotten the name. I didn't notice it.
Sarah.
Mr. Sarah. Mr. Sarah, I didn't notice your name earlier. So it's exactly as what you are saying. Okay. You know, we have intravascular space that's inside the vessels. Okay. We have intracellular space that's inside cells. And we have interstitial spaces. That is in between tissues, right? And extravascular can be either interstitial or intracellular. I mean, extravascular is anything outside the vessel, so it can be anywhere. Okay, but with respect to ascites and all swelling that leads to fluid accumulation in those areas, okay, you have fluid moving from mostly from intravascular space that's inside the blood vessels to interstitial spaces or into interstitium. Okay, so that is what happens in ascites, and you can't imagine ascites when you've not seen some ascites. Have you seen an ascites that I think a doctor or maybe a specialist has drained about almost 1 liter fluid and even still containing more, or let's say with more even coming out from the abdomen before. Have you seen some before? I think it's not too scarce to see. Okay. Those interstitial spaces can hold lots of volumes of water that you can't even imagine. Okay, so ascites is your answer. Okay, when you have ascites, ask yourself, all those fluids sitting inside the, or let's say sitting in between the interstitium, where are those fluid coming from? Okay, so they come from the intravascular spaces. Then they enter into those tissue spaces. Okay. So the answer is ascites. Please, you can quickly go through the rationale. So that's an example of a third space. I was asking the option two, another name for it, or the medical term given to it. Anyone here? I think we've seen this word before, but we didn't, maybe some of us have not paid attention.
Encro.
Sorry, it is like this rather. Something like this.
So there's no M.
Yeah, there's no yeah.
Yeah,
Yeah.
and corporaces. Yeah.
Yeah, and compresses, something like this. And compresses. So when you get a question and they tell you a patient is having and compresses, okay, or and compresses, you should know what that means. And mostly, the first time I saw this during my preparation, I was like, hey, someone who has a constipation, how can you have a watery diarrhea at the same time? When you read more about it, you understand. Okay. All right. If you have any question, you can ask. If there are no further questions, then I think we can continue. Mr. Janet. Mr. Janet, please, you can ask your question. Hello. Okay, Mr. Gloria. Please, can you hear me? Or my network?
Please, so I didn't hear about the
Sorry.
compressor. So please, if you can, let's go by first. Thank
So I was just saying the option 2 is end compressors. So end compressors, okay. The option 2. So you can read more about it.
Okay.
That is
Thank
the
you.
severe constipation causing you leak watery stool around a severely constipated or let's say when you
Hello,
have a severe
hello, sir.
constipation, you leak fluid around.
Hello,
Yeah,
sir.
I
Yeah,
missed that one.
compresses is mostly seen in children. There's this term they say,
in children.
need to
Yes.
sow. Yeah, need to sow. Yeah, that they have
Okay.
this saying. So mostly they become very constipated. But then during the day, you see strands of feces in their panty. That's
Mhm.
compresses.
Mhm. Mhm. So you can read more about it. Okay, you can read more about it and you appreciate it. Thank you very much for that addition. Let's do this one too. Which life-threatening complications would the nurse anticipate developing in the patient being treated for hypovolemic shock? So let all that apply. Let's do it together. So understand the question first. Which life-threatening complications? You're looking at life-threatening complications. Okay. Sorry, which life complications that the nurse will anticipate developing in a patient who is being treated for this. Who is being treated for this? So let's begin with the option 1. Is fluid volume overload a complication that can develop when a patient is being treated?
Yes.
It's not my handwriting.
Yes.
Yes, option 2, renal insufficiency. Can it be?
No. No.
Okay. Cerebral ischemia. Can it be?
Yes.
Very confusing, eh?
I baby.
Cerebral ischemia. Should we choose it? Or for this one, for NGN, we have our way out. So you will leave some out, and you choose those that you are sure. But over here, you know how our Q banks are. You will have to choose an answer by force. Otherwise, you'll be marked down. You know that. Should we choose it or mark it wrong?
Mark it wrong. Wrong.
Okay. Gastric stress ulcer. Can we get
Wrong.
it? Pulmonary edema. Can we get it?
Yes. Correct.
So we have 1 and 5, of which my handwriting is not part. 1 and 5. So you see, so this question, I think that's the time I flagged it. Let's go to the rationale and see. Fluid volume overload is not identified as a complication. So you see, this question is a bit dicey. Okay. This question is a bit dicey. I think where I took the question from and how it's being formed. It has two-way understanding. Okay. So this answers these answers here are rather identifying complications of what? I think hypovolemic shock.
Hypovolemic. Yeah.
Yes, rather than when you are solving it. Okay. So I understand. But if we have our content, I think you are good to go. So I think I will have to flag this question. All right, so let's continue. Pre-renal failure with
Boss, please
third.
explain it a little. Why 2 and 3?
Oh, we just said it too. You're not listening. So I was saying that the 2 and 3, this question was rather referring to complications of hypovolemic shock, not
treatment.
not the treatment. So there's an issue with the question. Do you get it? So
Okay.
so it has been flagged. So the answers chosen here were actually complications of hypovolemic shock. Okay, that is where you get renal insufficiency and cerebral ischemia. Okay, 2, 3 here. You know, fluid volume overload and pulmonary edema is like when you are treating this hypovolemic shock and you go overboard. Let's say you flood patients more. That is where you're going to get these conditions. And that is how the explanation of this question looks like. So it's like it is in the opposite. But what I'm trying to say here is we know our content, that's the key. Please, do you understand what I just said? Are we okay? Let's look at this one too. Pre-renal failure with third spacing, post-surgery. So when you hear of third spacing, I think I just mentioned it in a brief few minutes ago. So third spacing, it can be interstitial spaces. Okay. Third spaces can be interstitial spaces. So we are saying third space. So please, when you say interstitial, do we understand interstitial spaces or interstitial? Do we understand? Okay, I think we all understand if nothing is coming. So when we say third spacing of fluid occurs 24 to 72 hours after extensive abdominal surgery, what we mean by that is there is increased capillary permeability. Okay, you know, after especially surgeries like abdominal surgeries, you mess up with tissues and blood vessels and the rest. Okay. And when you do that, though we are solving an issue, though, but when you do that, you end up increasing capillary permeability, and that can easily lead to fluid accumulating in interspaces. Okay, on the interstitial spaces. You remember, according to the virtuous triad, we have another one like I think intravascular injury, right? Or how do you call this one? Endothelial damage.
Endothelial damage.
Yes, endothelial damage. So it is the same thing here. So it's like when someone undergoes any abdominal surgery, you can talk about lots of things that can result as complications. That's why, after that we have some like we have this English thing, like we have some antibiotics we give just as a preventive measure of to protect you from getting infection, okay, as a preventive measure. Then we give you some should I say anticoagulant, yes. We give you some anticoagulant too, just to take care of that part, okay. That's part of endothelial damage in virtuous triad. That can increase your tendency of getting blood clots within your vessels, and it can dislodge or can be trapped anywhere and cause issues. Okay. So whenever tissues are messed up, especially in situations like abdominal surgery, what we are saying on this slide is that you increase capillary permeability. Okay. And it occurs when too much fluid moves from intravascular space to interstitial or third space. So that's a space between your cells where fluid does not exist under normal circumstances or situations. So it can be injured sites or peritoneal cavity. Those are easy areas that some of this fluid can accumulate. That's okay. And we're saying this fluid serves no physiological purpose. Okay. Whichever fluid that is in your stomach is serving a purpose. Whichever fluid that is anywhere where you have fluid, naturally, is serving a purpose. But you shouldn't get any fluid in between your cells, okay, or in between your tissues. They serve no physiological purpose. And that is what, and do you know one funny thing, like we explained for that question, that question that we chose ascites, all those fluids will be coming from intravascular spaces, then will push or find their way into tissues, okay, like between tissues, interstitial spaces. And because these fluid are leaving intravascular space into interstitial space, the volume within the intravascular space will decrease, leading to decreasing circulating volume or circulatory volume, in this case, hypovolemia. And that will also eventually lead to low cardiac outputs. So that is what we are seeing here. So let's take notes. Okay. Let's take notes. So when this happens, the priority is to what? Remember, we have fluid moving from intravascular space into interstitium. Okay. When this happens, and let's say you happen to get a question about these things, and I wish I can give you more sensitive question around this series, but there will be like, which of the following assessments will be your priority? In this case, vital signs is better, because vital signs generally measures your blood pressure. And if you are losing blood pressure can take it up, or it can pick it up. Though it's not more ideal, but at least you will know that the person is losing blood volume. Heart rate will give you an idea. Okay, you get tachycardia, for blood pressure, so you get hypotension. Right. Then we have some other vital signs you can also check. So when this happens, as you, the monitoring nurse, checking vital signs is your priority. Okay. When it comes to third spacing and the rest, checking vital signs is your priority. And weight is even a form of what vital signs. And you realize that they tend to gain weight a lot. Okay. And they have decreased urinary output, because the fluid that should be able to reach the kidneys and the rest, and for urine to form for the bad part of the blood to come out as urine, you have most of them pushing their way into interstitial spaces. So the person will tend to gain weight and will have decreased urinary output. And that can eventually lead to even multiple organ damage. Kidneys will fail, liver can fail, lots of organs can fail. Okay. All right. And the last point here, we are saying if test space is sorry. I'm saying if test spacing not recognized and correct. Sorry, if test spacing is not recognized and corrected, postoperative hypotension can lead to decreased renal perfusion, so like I said, and pre-renal failure, and definitely hypovolemic shock. So we have three types of renal failure, right? We have prerenal, postrenal, and intrarenal, right? Apart from hypovolemic shock. Okay, so let me cut it, let me make it simple and round it up. For those of us who have forgotten, just as a revision, prerenal failure, you know, in the normal sense, okay, or in the normal physiology of the body, you should have blood entering the kidneys, right, to be filtered. Then after filtration, the good parts will stay, excess or bad parts will come out as urine. When you have prerenal failure, you have issues with the amount of blood coming to the kidneys. So just in case you get questions around prerenal failure, think that way. Anything that is reducing the amount of blood reaching the kidneys will give you prerenal failure. So hypovolemia, hypovolemic shock, excessive bleeding, okay, like hemorrhagic shock and the rest, anything that is preventing blood from reaching the kidneys is pre-renal. Intrarenal has to do with injuries within the kidney themselves, okay? Or infections can also cause it within the kidneys, like pyelonephritis and the rest, okay? Then we have postrenal failure. Postrenal failure deals with obstructions, things that obstruct urine flow. You know, let's say, assuming your ureter, something is happening and there's a blocked urine flow. You know, the kidneys will continue to produce urine. I mean, at all points in times, okay, it will try to produce the urine. But if it doesn't get anywhere to go, okay, it will mount up pressure depending on where the blockage is. So if it's within the ureters, you see a mount up pressure over there, and definitely the pressure will mount up and reach the kidneys and will shut down the kidneys. So think of anything, strictures too, okay, like strictures, anything that blocks urine flow. So think of all of that to be causes of what post-renal failure. That is just by the way. I have a nice question here for all of us. So for which patient is the nurse most concerned about the risk for developing kidney disease? If you want to try, you can raise up your hand. Who wants to try? Are we tired? Or someone wants to try? Today I've heard of only one male's voice. Only one male. My guys, are you here? Apart from Nanayo. My guys, are you here? Brian Rich, are you here? So no one knows the answer to this question. Anekia, you want to try, right? Or Ramatu? Wow. But please, can you hear me?
Yes, sir.
Hey.
Yes, please, we can hear you.
Oh, okay. Let
Hello.
us choose something.
Yeah,
Hey,
answering in the chat.
oh, come on. Talk to us. It's Ellen, try. So whatever thing you put in the chat, just raise up your hand and tell us here. Sometimes because of how my things are here, I'm unable to go through the chat always.
Hello.
Yes, sister. Sister Jane,
Yeah, Emma, can you hear me?
I can hear you now.
I think my this thing was not working. My speaker was not working. I will go for B because we're talking of anything that will cause obstruction. I mean,
Okay.
if there should be kidney stones, it will probably cause obstruction.
Okay.
Yeah,
Oh,
I got it.
but
It's
you
it.
didn't get anything. You didn't get
Who is in the
anything.
chat? Please check.
No one
It's it.
spoke. No one spoke. You didn't get
I was
anything.
about to speak when my sister started speaking.
Okay. So, okay, so let us look at something. 25 year. Okay, so I think with the A, it was of no concern. Let's look at the B. A 55-year-old patient with history of kidney stones. History. A history of kidney stones. It's not an actual problem, just a history. Or when someone has type 2 diabetes, you know the polyuria part. Okay. Polyuria part. And which type of kidney disease is this patient likely to develop? Those of us who said they had it in their minds.
Is it nephropathy?
Okay. Yes. So that one is there. So which type? Which type of renal failure?
Is it the stages of renal failure or?
Like in terms of pre-renal, I mean causes. Pre-renal, intrarenal, and post-renal.
To be intra.
Intra. This is more of intra, yeah. Okay. We have another one here. A patient who has acute glomerulonephritis is hospitalized with acute kidney injury and hyperkalemia. So which information will the nurse obtain to evaluate the effectiveness of the prescribed calcium gluconate IV? This question is very easy, but tricky. Just small one. The tricky aspect is very, very small. Let's see who will get it. Please talk to me. Don't answer in your mind or don't use the chat. You just talk to us. And some people feel shy when they get it wrong, or they feel shy that they will get it wrong, so they don't want to talk at all. Talk to us. We are all learning. So which information will the nurse obtain to evaluate the effectiveness of the prescribed calcium gluconate? LACO.
So the option will be C, the cardiac reading.
Cardiac rhythm. Cardiac rhythm. Okay. Okay. Can you explain why?
Okay, so the person here is suffering from hyperkalemia as a result of the kidney acute glomerulonephritis. You know, hyperkalemia can be managed with
I'll switch it from start topic.
gluconate.
Please continue, okay.
So with calcium gluconate, it's used to treat hyperkalemia. So to determine if the hyperkalemia is resolving, you can use your cardiac readings to tell that.
Okay. Thank you very much. Any other? Thank you,
I will go for A. Urine output.
And why?
I'm looking at it that if the kidneys is having issues, there will be less urine output. And so once you are able to assess that the urine, hey.
Oh, continue. Oh, continue. I'm enjoying it.
Oh, that's I'll hold on.
You're trying to make some nice points there too. Okay, so when we give calcium gluconate, when we give calcium gluconate in hyperkalemia, the issue is to protect your heart. Okay, it has this cardioprotective property from getting lethal dysrhythmias and definitely leading you to arrest. Okay, so the main reason for giving calcium gluconate is to give you that cardioprotective effect to protect your heart from bad cardiac rhythms. So let us take note of it. We can read the rationale to add up. But if you have any question, you can bring it up. If you have any question, you can bring it up. Okay.
Hello, Zaima.
Yes, sister.
Yeah, my question has to do with the one that the answer was ascites.
Okay.
I think I had a question, but I couldn't ask because of the speaker. So the phenomenon, does it happen to all issues of ascites? Because I know when it comes to heart failure, there is ascites, there is edema and all that. But then they have the fluid volume is more. And so we don't even give IV fluids and so on. Is it different from the phenomenon that is happening here?
Okay, so I think we explained better, but maybe because your speaker wasn't working, so you didn't hear us. So, cardiac issues can give us ascites, even liver cirrhosis or liver issues can give us ascites and some other things. Okay. Yes, you are right. But what happens in ascites is that all the fluid accumulation over there, they are from intravascular space. Okay, from intravascular space, which collects themselves within those interstitial spaces. Okay, and when you have, blood volume, which should sit, or let's say intravascular volume, which should sit within the vessels to help perfuse vital organs. When you have them moving into interstitial spaces, then you're going to have a severe shock, okay, hypovolemic shock in this case. And please, it's not only ascites, any form of fluid collection into third spaces. So when someone has something like anasaka, I think anasaka is generalized edema, right? Anasaka, when someone has anasaka, where, when you have lots of fluid moving into tissues, that one is generalized one, like all over. Ask yourself, where are the fluids coming from? From intravascular spaces. So don't think of only ascites. Like when you have fluids, fluid collection into interstitial spaces, what it means is that they're all coming from the intravascular space. Please, do you understand what we are trying to say? Or I have not answered you well. Was it again?
Yes.
Have I answered you? I have not answered you.
Partly.
So which was the ending part of your question was what?
So I was looking at the fact that ascites, it has fluid accumulation, and so definitely
Okay.
going
Okay, so let me
hypo.
take it up from there. Okay, so when you have fluid moving from intravascular spaces into interstitial spaces, you have decreased blood volume. Okay, those fluid that you have in the interstitial spaces, they are having no physiological function. Okay, and they are rather causing issues. Let me use the ascites you just spoke about as an example. When you have fluid accumulation within the interstitial spaces, like in the peritoneum, they even put pressure on the diaphragm. Okay. Reason why we don't even want to overload, like treating those conditions, you have to be very, very careful because this patient needs fluid actually. Because whichever fluid that is, so it's something, okay. Most of the times and for those people, I've about I will not say 100%, but about 99% of those people, they have this condition, hypoalbuminemia. Their albumin levels are really low. Hypoalbuminemia.
Yeah.
For about 99% of people like that. So what does it mean? The protein albumin, which is supposed to draw fluid by means of oncotic pressure from interstitial spaces into blood vessels, they are loose, or they are no more, they are not there, or they are very, very less, so they can't do their work. So whichever fluid you give to these patients, it will still end up moving into the interstitial space. So the goal of treatment in those people is to tap those things when excess and to give lots of albumin. So they end up giving FFPs, human albumin, with respect to their diet, high protein diet and the rest. So anything just to increase blood proteins to help draw more of the interstitial fluid back into the intravascular spaces. Okay, so you don't consider the fluid in ascites as a blood volume. It is outside the blood vessels. So it's rather causing harm than good. Please, is that clear now, or it's still not clear?
Yes, it's clear.
Okay. Thank you very much. Any other question?
Hello, sir.
Yes, sister.
Please, so does it mean that these patients, you don't give, if you have the option, you go for albumin instead of IV fluids to treat the hypovolemia?
Hypovolemia. Okay, so you see, this ascites is a special case. Okay. But when you have hypovolemia, the standard goal of treatment, just hypovolemia, the standard goal of treatment is to give isotonic fluids. Okay, like Ringer lactate. And for that one, whatever thing you give will sit in the blood vessels and help. And if possible, you can add vasopressors and the rest to help maintain blood pressures and vital organ perfusion.
Sorry, please, I was talking about it in terms of this third spacing.
Yeah,
exactly.
Yeah, so you can't say giving fluid is contraindicated. It is never contraindicated. So you do it together, okay? Because the person will still need fluid, though. So most of the times, I think they even give them a drain. So fluid should by all means go into the system. You should give the person fluid. Some will go into interstitial spaces, though. But in order for you to ensure that lots of the fluid you are giving also stay in the intravascular space, you add that plan. So you do it in conjunction, okay? You don't do, when you give only fluid, you are worsening situations rather. When
Okay, sir.
when you give only fluids, you are worsening situation. The person will definitely need fluids, but the person will need more of blood proteins. So whichever fluid you go, whichever fluid you give to patients, you have some or plenty staying in the intravascular space. And even some of the proteins even trying to pull some of the interstitial fluids back into the intravascular space. There's a mechanism for that too. Please, are we
Okay,
clear?
sir. Yeah, we are clear. Thank you.
Okay, you're welcome. You can find out about more. It's very interesting. You can find out, more about that and see. Let us answer this question quickly so that we can end today's class. Who wants to try? If you want to evaluate kidney function, which one among the options here is the golden standard? Hey, this one too will not talk.
C, please, C.
The answer is
A.
D, right?
D.
You are saying A. So it is glomerular filtration rate. That's why most people were quiet. So in this case, let me check the you see the chat. Many people are writing B and C. Okay, but the answer is glomerular filtration rate. Please, when you go when someone let's say a patient does this electrolyte, okay, no, RFT, renal function test. Do we use the creatinine level to diagnose the kidney function? I want us to use that example. Do we use the creatinine levels on the report to diagnose the kidney function, or we use the EGFR, estimated glomerular filtration rate? Which one do we use? So you see the trick here. Okay, between urinary output and BUN takes it. Between BUN and creatinine levels, creatinine level takes it. But between creatinine levels and estimated glomerular filtration rate, this also takes it. Actually, it should be above 60 going. Normal one is, I think, 80 and above, but when you fall below 60 for most lab results, you have kidney injury. All right. So I think we should end here and continue next time from where we've gotten to.